Hello, everyone. I'm Amr Al-Khadim. I'm a professor of prosthodontics in the Cairo University. I'll be talking with you today about the digital bite registration. So the topic is a little bit tricky because everyone doing conventional prosthetics know that doing a bite registration for dentate patients is an easy job. We just follow the normal teeth. But when we are doing a bite or a jaw relationship for an edentulous patient, it's a little bit more tricky and more difficult. And when you go for the all-on-X, it becomes a little bit more challenging for everyone. So my talk today, I'll be talking the first about the concepts of the jaw relation records, because this is very important. I know a lot of people, maybe a lot of the people attending the seminar today do not like doing dentures. But believe me, the main concepts behind jaw relation records for all-on-X is the same as doing a complete denture. So I have to go a little bit with a glance on the concepts of centric relation, centric occluding relation, maximum intercuspal position in the vertical dimension. I'll go like 10 minutes talking about this. Then I'm going to talk very fast about the active and passive techniques for recording the centric relations. Then I'm going to start the digital part and tell you how you can get the best possible digital jaw relation record for the all-on-X cases. So let's start together this like 40 minutes journey together. I'll go back to the basics, which is the mandibular movements and the kinematics in order to understand the concept behind the centric relation. And everyone during the undergraduate years have heard about the envelope of motion and how the mandible is moving within the range of the motion, which is dictated by the condyle, the muscles, and the teeth. And we have like a trajectories when we are doing the different mandibular movements, we can see it in the different 2D planes. But I'm really interested to talk a little bit. So what happens when we start from the what we call the centric or the retruded contact position, which is the start and ending point. And this is what we call the centric relation. And then from this centric position, the main movement we do is the opening and closing. And this is part of the curve. This part, we're going to talk about this a little bit in details. And then you can slide from this also starting point, which we call the centric, to the front a little bit, what we call the intercuspal position and where the movements occur. And so this centric position is actually simply, it is the start and end point of everything. It is the physiologic point where the muscles and the anatomy of the temporomandibular joint tend to set the relation between the maxilla and the mandible. And consequently, what we need to know is that when a patient has teeth, he might be a little bit in the contact between the teeth, a little bit in front of this, which is called the maximum intercuspal position. But usually, when we do not have teeth and we want to reconstruct the whole occlusion, the most reliable point to set up our occlusion is this point, which we call the centric position. And I want to talk a little bit about this because there are two things we need to address, what we call the centric relation and the centric occluding relation. We knew from the last slide that this point, which is the 0 point, the starting point, is called the centric. And actually, during this centric, the condyle is actually stable in the lower compartment of the temporomandibular joint, and it can slightly rotate inside the lower compartment without being translated. And the patient can perform like a small rotational movement from here to here. And actually, the condyle, which is here right now, is rotating slightly inside the lower compartment without any translation, and the patient is opening a little bit from here to here. And since the condyle is not moving, it's not translated, we can understand that at this position, the condyle is centric, and at this position, the condyle is also in the same position. And every way through this path, you can see this part of the path, the condyle is still in the centric. So there is a range of motion, an opening and closing motion, where the radius of rotation between the condyle and the incisor point is called the radius of rotation. And during the whole path, this condyle is always in the what we call the centric position. And actually, when we join this center and this center together, what we call the hinge axis, and we measure the distance from this hinge axis to the mid-incisor point, this is called the radius of rotation. And this concept is very important because when we're doing full mouth rehabilitation cases, and we have a patient that has a lower or a higher vertical dimension, and we just record the vertical dimension at a certain level, and we want to close or open the relationship on the articulator, whether digital or virtual, we have to calculate this radius so that we can do or perform the function, the same rotational function that we do inside the patient mouth on the articulator. And this is what I'm telling you. I want to say an exact term here. The centric relation is a 2D relationship. It's a two-dimensional relationship, which is a relation between the maxilla and the mandible when the condyle is in its zero position. We will discuss this zero position in a moment. And technically, the word centric is 2D. It's anteroposterior and mediolateral. And it is missing what we call the third dimension, which is the vertical dimension. And actually, if you look at this, if this is the condyle and this is the incisor point, this one is centric, this is centric, this is centric, this is centric. All this pass, we can consider the condyle centric. But when we have an exact vertical dimension of occlusion, the only centric relation that coincide with the proper vertical dimension, we call it the centric occluding relation. So the word centric means a condylar position between maxilla and the mandible, irrespective of the third dimension, which is the tooth contact. But when we add the vertical dimension of the patient, it becomes a three-dimensional relationship, which we call the centric occluding relation. I know this is very basic, this is undergraduate, but this is important to understand what I need to do later on. So the first question here, do we need to measure this radius, which is the distance from the condyle to the mid-incisor point for every patient? Really not. If you're taking your jaw relation records, you're taking the centric at an exact vertical dimension that you will not going to change during the course of the treatment, the measurement of the radius is irrelevant. You don't have to do it. But if you're doing a full mouth case and you're taking a vertical dimension and maybe later on you're gonna increase it a little bit or decrease it a little bit, and you want to maintain the proper horizontal, mediolateral, and anteroposterior despite you're changing the vertical one, you have to measure the radius of the rotation. And to measure the radius, we have three ways. The classical old way is taking a maxillary phase bow transfer, because the job of the maxillary phase bow is just to connect the posterior reference, which is the condyle, with the anterior mid-incisal point, and consequently you're measuring the radius from here to here. The modern ways to do it, if we have an integrated face scan or a jaw relation, an intraoral scan with the CBCT of the patient, if we can determine the center of rotation of the condyle, we can also calculate the radius. And most recently, we are starting to take face scans, and by determining the arbitrary point on the face scan, we can also measure the radius of rotation. So the first question, do I need to measure the distance every time I'm doing a full arch case? I'm telling you, if you are going to record one exact vertical dimension and you are not going to change it, the measurement of the radius is not critical. But if you intend in a full mouth case to just decrease the vertical or increase the vertical a little bit on the articulator, you have to measure the radius so that the change you're doing virtually or physically on the articulator is the same as the patient movement. And this is important. So let me define what is the centric. Really, the definition of the centric has changed a lot. And maybe some of the guys will like the definition I'm telling you now. This is the definition from 1956. It's almost 75 years ago. They defined the centric like the most retruded relationship between the condyle and the maxilla, when the condyle is in the most retruded, unstrained position. And really, the definition is telling us that we have to bring the condyle as far back as possible. And they are calling the unstrained position. This definition was there from like the 50s up to the 80s. And the definition had a lot of problem because they were telling us to push the condyle to the most posterior point, the most retruded, but it has to be unstrained, not to do pressure on the posterior elastic ligaments. And they were not considering the disc in the equation. Where's the disc? So it was really an inaccurate definition. And in the 80s, we started to have a new definition for the centric relation. And this, what we can call new now, it's not new, it's like 40 years ago. It's the relation, the centric can be defined as the relationship between the maxilla and the mandible when the condylar disc complex when the condyle articulates with the thinnest avascular portion of the disc and both complex is in the anterosuperior position. So now, when the definition changes, the condyle is no more in the most retruded, it's not here, it becomes up here and in the front. So it's a little bit a big change. Believe me, it's like 1 millimeter. And actually, I'm telling you the definitions not for the sake of the definitions, but because the technique of registering the jaw relationship has changed. And this brings me to the important clinical question, which is the aim of the past like 5-10 slides, is to go to this. How to place my condyle in the centric? Actually, we're having two main ways, what we call the passive techniques. And the passive techniques means that it's operator guided, which means that the operator is the one who's gonna guide the patient into the centric position. And there are techniques called the active techniques, which is patient guided, means that the patient is the one who's gonna bring himself into the position. We have three passive techniques, which is the chin push guidance, the bimanual guidance, and the Ramus assisted chin push. And the active are the swallowing and the tongue retrusion. Let's go a little bit with this. If you believe in the definition of the most retruded, which means that you want to bring the condyle as far back as possible, what you need to do is that you have to put your 2 fingers and thumb below the chin of the patient and push the chin as back as possible, just to bring the patient in the most retruded. And believe me, this is not the best way, because when you do this, actually the patient gives you a back reaction and he started to push in the front. And this is one. Number 2, if you do too much force, you're bringing the mandible too much posterior, and technically this is the retruded position, so it's not accurate. Number 3, if you are a right-handed operator and you push the patient to the back, probably he will go to the back and a little bit to the left. And the opposite happens when you are left-handed. So you are not mediolaterally centralized in many cases. So it's not the best way, but this is how the most retruded guy used to record the jaw relationship. When we start in the 80s, probably in the 80s, when we started to know that it's not the most retruded, maybe it's a little bit top, so the technique was changed a little bit. And now the people who are doing chin pushing are putting the 2 fingers, the middle and the index finger, they are putting it below the inferior border, and they are putting a little bit of upward pressure with the backward pressure. And this is called the Ramus assisted chin push guidance. But now the standard of doing a proper centric relation, which is called the bimanual guidance. And the bimanual guidance means that you're gonna put the patient in a semi-reclined position, maybe a 45-degree or maybe more reclined position, and you start placing the 4 fingers probably at the inferior border close to the angle, and the 2 thumbs from the 2 sides at the chin. And the aim of the bimanual manipulation is to push the mandible up so that I can put the condyle in the anterosuperior position. So the change in the concept from the most retruded to the bimanual is made to bring the condyle from backwards to up. And this is the best way. And believe me, it's a little bit hard to train for this, but if you want to get the best possible anterosuperior position, I believe the bimanual guidance is the best way to do it. For the active techniques really aims to help the mandible go back to the 0 position by the action of the muscle. And you can do it by asking the patient to swallow, because the mylohyoid muscle will be in action and it will pull the mandible a little bit to the back. And also the tongue retrusion, because of the genioglossus muscle, will pull the mandible back to the position. Usually, you can combine both of them. You can do the bimanual manipulation in addition to tongue retrusion, because if you rely only on the active techniques, you depend on the patient cooperation, and this is not always the best way to do it. So I would recommend that we combine the bimanual manipulation, probably with the tongue retrusion,
and not to do the tongue retrusion alone. So now, this is called the centric relation, and we agreed together that the centric relation is a 2D relationship. It's a mediolateral and anteroposterior, and I need to add the third dimension, which is the vertical dimension occlusion. So I don't need any of these green centrics. They are all centric, but I need the red one, which is the centric occluding relation, meaning that the condyle is in the anterosuperior position and the patient is biting at the correct vertical dimension of occlusion. And this brings us to the question, how can I know the vertical dimension of occlusion if the patient does not have teeth? And definitely it depends on the patient face. Some people, some experienced people would know that this patient is definitely a low vertical dimension patient and this one is good. From the facial feature, you're telling me he has dropping in the corners here, the lips are everted outside, but this patient, the lips are lightly touching, the mentalis muscle is not active. So it can depend on the clinical experience of the facial expression. But believe me, this is not the best way that everyone can do it. The best way we can calculate the correct vertical dimension of occlusion is by using the facial proportions. And we know from the sculpture that the face can be divided into 3 equal portions. The first one is starting from the hairline to the nasion, which is the most depressed part between the eyes. The other one from the nasion to the base of the nose. And the third one from the base of the nose to the tip of the chin. And because the hairline is not constant, I'm a bald guy, I don't have hair, so you cannot depend on my hair. So the upper third is not fixed because of the hairline is changing. The lower third is also not fixed because it depends on the absence and presence of teeth, but the middle one is fixed. So what I always do is that I do a measurement from the nasion to the base of the nose, and I want to have the patient biting so that the distance from the base of the nose to the tip of the chin is equal to this. We do use digital calibers to do this. So when I do the measurements here, I know for sure that this patient requires a little bit of an increase so that this lower part is equal to this middle part. So I believe this is one of the very, very useful tools. Just that you have a manual or a digital caliber just to do the measurement, because this will give you a good indication of the correct vertical dimension. It is not a solid number. It's not about an exact number. There is a leeway of like 2 to 4 millimeters up and down. So if I'm having a calculation, I might go a little bit up 2 millimeters, maybe 2 millimeters down, based on a lot of factors. But if you stick to the third, the mid third is equal to the lower third, you would always have a good vertical dimension. And I want to tell you something, that in most of the people with the natural teeth, the maximum intercuspal position is not the centric. People usually have teeth with cuspal interferences. So if you close in the centric, the teeth are not maximally contacting each other. So the people tend to shift a little bit to the front so that they achieve the maximum intercuspal position. And this is normal, as long as the patient is not complaining, he's not having TMD problems, so don't touch him. But when you have a patient who is edentulous, or a patient that you are reconstructing the whole occlusion, it's not allowed for us to have 2 different positions, to have a centric and maximum intercuspal, because you're not sure if this would be comfortable for the patient. So our job when we're doing full mouth rehabilitation is to construct the maximum intercuspation of our new dentition in the same position of the centric occluding relation. I need to emphasize over this. With natural teeth, we might have a difference between maximum intercuspal position and the centric occluding relation. They might be different. In 90%, they are different. But when we are reconstructing occlusion, please, please, please stick, because this is the most reliable one that we know that there is the least liability of causing TMDs for the patient. So in brief here, before going to the real part of the seminar today, I was just revising some concepts for the guys, that there is a difference between centric occluding relation, and maximum intercuspation. The centric are many relations because they lack the third dimension, which is the vertical dimension. So the condyle has to be in the anterosuperior position, and the teeth might be contacting or not. But in the centric occluding, The condyle is in the anterosuperior, and the teeth are contacting at the exact vertical dimension. In the maximum intercuspation, the condyle position is not essentially what we, the centric one, but we have like maximum intercuspation at this position. Let me tell you something. Is the centric really a point? Because we were taught in the dental school that the teeth should be contacting like this, in what we call the ABC contacts. And really, if you see what happens by time with people are developing an occlusal attrition. And this might be because the incoincidence between the centric position and the maximum intercuspation, so it's not comfortable. So the patient start to grind a little bit front and back, and the teeth becomes a little bit worn off. They are not as sharp as this. And we are trying to mimic this. And now, probably from the 70s, we're having something like what we call a long centric. We don't like, especially in the implant prosthetics, and really even in dentures, we don't like the sharp cusp to fossa contact, the very sharp cuspal contacts. It's not good, because if you have a little bit of interferences, you have a big problem, chipping in, probably implant problems and others. So we like to have like a slightly wider fossa and a little bit rounded cusp. And this is what we call the long centric. And this gives us permissibility a little bit. It's not too much permissibility, because if you make it flat like this, you lose the cutting efficiency and becomes really not aesthetic. So I'm just looking to a compromise between the left side and the right side. And this is why we like to define the centric a little bit as an area, a long centric, a wider fossa, and a less sharp cusp. Okay, let's go to the real topic today. Now I'm having a patient that I placed the full arch implants, and I need to register the jaw relationship. We have probably like 3 ways of doing this. I will go with the 3 ways and tell you the differences between them. So the first way to do with this is to utilize what we call preoperative records if the patient is having a temporary. The second way is to create what we call an anterior deprogrammer. And the third way is to use occlusion block records. So let's go with the 3 methods. The first way to do it is when you have a patient who have already an implant-supported temporary, as the one in the video running now, or maybe he has like a few teeth before the final scan, I can use them. So if I scan the patient, initially I scan the patient with the temporaries in place. The temporaries are really a big treasure, because the temporaries have been in the patient mouth for a time. The patient is very comfortable with this occlusal relationship regarding the centric and the vertical, both of them. So if I record just a preoperative scan with the bites, I can just subtract the teeth from this scan and continue the scan from my scan bodies. And consequently, I'm getting the relationship between my teeth and maintaining the same jaw relationship of my temporaries. And I'm telling you, this is the best possible way to have a good digital recording of the jaw relationship. You see, for this case, this patient had an implant-supported, immediately loaded restoration with the opposing arch. And before doing anything, I just scan the bridge. I'm just scanning the bridge. I'm scanning the opposing arch, and I'm taking the bites. And probably, if you feel that the bite is not correct, you can just do some minor occlusal adjustment with the articulating paper, adjust the bite with the vertical and the centric, and you can use always this to record a pre-operative relationship. And believe me, this is the best way. The only problem with this is that when you do the pre-operative scan and you start cutting off the teeth and you're going to scan your scan bodies, you have to have a reference. In the maxilla, it's not a big deal, because you can always go to the palate and start the scan. In the lower arch, you have to extend your scan a little bit back to the bridge so that you get the retromolar path, so you can use it as a reference. If you cannot do so, you need to, after scanning the bridge inside the patient mouth, you need to cut it off into 2 pieces with a burr. Keep 1/2 and remove the other, and then you scan the scan bodies at the one side, and then you remove the other half of the bridge and you scan the other part. So you can do it like in a fragmented scan, and then you can just join the temporary bridge again with some core material or flowable composite. But probably it goes easier than this if you scan a little bit more of the tissues behind the bridge. So this is the first way, the easy way. Let's go a little bit if it is hard. You don't have a temporary for the patient. You just place the implants and you scan the implants, and you want to take a jaw relationship in the same visit. Okay, from the previous talk we had at the start of the seminar, we know that the centric relation is an medial lateral and anteroposterior, and it's lacking the vertical part. So what we need to do is that we need to create a vertical stopper, usually at the most anterior part here at the front part of the teeth, so that when the patient is biting on this, I can scan the patient from the right and left and get the jaw relationship. So the logic of an anterior programmer is to create an anterior stopper. Okay, and this anterior stopper is either placed in the most anterior point, probably at the midline, or maybe two bilateral stoppers at the premolar region. The aim is to stabilize the centric relation at the required vertical dimension. When you are creating this deprogrammer, it's not like a bite, it's just a stopper. It has to be flat, because if I just put like some putty material and ask the patient to bite and I have indentations, it might be wrong. So the patient, I cannot check it multiple times. There might be a deviation. So it has to be like a flat plane, and the patient is biting and I'm checking multiple times that it's a very viable centric relation so that I can proceed. So what is my material of choice? If I'm doing this, I like to use the green stick compound. I know a lot of the guys maybe attending this webinar probably don't know this, or maybe forgot it from the dental school. This is a type of thermoplastic wax. It is a very nice material because if you put it in a hot water bath, it becomes very soft. You can adapt it and shape it like the way we're going to see in a moment, flatten the top, and then you just spray it with some air or maybe some spray. It becomes rigid and very hard, so that when the patient is biting over it, it is stabilizing the jaw relationship. Can we use other alternatives? You know, there's something called the Lucia jig or the deprogrammer jig, but probably it's made for the patient who are having teeth. But because we don't have teeth, the customization of those Lucia jig, it's really a little bit tricky. So I believe this is the best material to use. If you try to use pink waxes, the pink waxes can be molded easily, but they are not sufficiently rigid. So the patient, when the patient is biting, he might do a little bit of overclosure. And the silicone, on the other hand, is good, but it's compressible. So the patient, when biting over the stopper, if you make the stopper out of putty silicone, it would be a little bit compressible. So let's see how to use this very nice material to create the anterior deprogrammer. There are different ways of doing this. The idea is the same. I want to create like a stopper like this, an anterior stopper. This anterior stopper, the aim is for the patient to bite a little bit over it so that the vertical relationship is maintained at the centric relation, which we get with the bimanual manipulation or whatever technique that we agreed to use. So there are different ways. I'm going to show you different ways of using this green stick deprogrammer to get the proper jaw relationship for the patient. So let's start with the first way. When I do a scan, I'm having a scan for the patient. Probably I'm doing a scan with the scan bodies. So I'm going to use my scan bodies as a holding platform for my deprogrammer. Okay, so how to do this? For instance, this patient, we had a scan like this. This is a splinted scan. This is the scan body. We join them to make the scan a little bit easier. And then we ask the patient to bite. In the cases when the scan bodies are not long, they are not interfering with the vertical dimension, we can just ask the patient to bite over them. If the jaw relationship or the vertical is a little bit low, we just put the compound here at the middle part over this platform and ask the patient to bite so that we have the proper vertical, and then we can scan from the side here and the side here. So if your scan bodies are shorter than the interarch space, you can add the stopper over the scan bodies or the splint material. I have seen this paper. I didn't use this yet, but some guys are doing a very nice job with this. They are having like some sort of a multi-unit with a screw, and they are just adjusting this screw up and down till the patient can bite over this, so that we can stabilize the vertical dimension and we can scan the bite from the right and the left. So the aim here is to use the scan bodies itself as a platform for holding the vertical dimension by adding the grease stick material or maybe those screws just to hold the vertical dimension. But actually, this scenario is not doable every time, because at many instances, the length of the scan bodies is not short enough. They are long scan bodies, so they are interfering with the occlusion. So I'm going to show you another way for the guys who are using the photogrammetry. The photogrammetry comes with some small scan caps, which called the cap scan bodies. They are originally designed to scan the very difficult cases with movable soft tissues, but we can use them also for the bite registration, as I'm going to show you now. I had this patient. This patient had I made him a full arch implants in the lower arch. He had a complete denture in the upper, and he had like flabby tissue from his old denture. So the soft tissue scanning was very difficult. And for the photogrammetry purposes, we were using the cap scan bodies. You see, this anterior part is all flabby. I'm just doing a very big retraction to pull it out. So now I scan them, and then I put my compound. You see the compound here, the patient is biting on the compound. I'm scanning the bite on the right and on the left. And because the soft tissue scanning is very difficult, the software cannot align them together. I'm just taking a bite for the right and the left. The software alignment is not good at all because there's insufficient amount of soft tissue in the lower arch for the software to identify the bite. So the nice thing is that we can go to the Shining software and do manual alignment. I'm using the teeth of the upper denture and the exact shape of the scan bodies. I'm just selecting 3 points at the upper and 3 points at the lower using the sharp parts of the cap scan bodies, and now it is aligned properly. So the idea here is to stabilize the bite with the green stick compound over the cap scan bodies and utilize the cap scan bodies for aligning the bites together using manual alignments. This is a very difficult case to scan, but technically, because we can use the software for the manual alignment, everything goes correctly. The third way to do it is if I'm having a case like this, the space is very limited and the scan bodies are a little bit high, we can use the multi-unit abutment itself as a holder for the deprogrammer. So what we do now is that we just soften the green stick compound in the warm bath, adapt it over one of the multi-units, flatten the top, and ask the patient to bite. And then we measure the vertical dimension. If the vertical dimension is high, we just re-soften it, press it a little bit to the downwards so that the vertical dimension is okay. If the vertical dimension is low, we can always soften it, pull it up a little bit so that we adjust the vertical dimension that we need. And once it's set, because it is stabilized by one of the multi-units, it is rigid in place. And this is very important, because if this part is moving, the whole logic of registering digitally the jaw relationship is inaccurate. So what we need to do now is that we modify it, and then we scan the scan bodies, and we scan the opposing, as you can see here, and we adapt this at the correct vertical dimension, ask the patient to close over it repeatedly, 1, 2, 3, 4, 5 times, till we make sure that this is the centric position, and then we scan part of the left side, it is aligned, we scan part of the right side, it is aligned, and the job is done. It is as easy as you can see it in the video. So just create an anterior stopper with the green stick compound is just a very simple trick that works at many instances in a good way. Okay, we can also use like an impression tray as a holder for my deprogrammer. And this is really beneficial when you are doing like a combination between physical scanning for the tissues, and also you need to record your scan bodies. Let me show you a case. Sometimes when we're preparing our patients for a denture or maybe doing an implant-supported restoration, we take a tray and we make an impression and we scan the impression. When we scan the impression with the software has the potential to just invert the scan and makes a positive model for the work. So now I'm having a model, and then I put my green stick compound maybe bilaterally and take my jaw relationship, and I scan the whole assembly, the tray with the compounds as one piece, and the software can align both of them together. The software for the shining for the denture module. This can be done with the denture module in the shining software. So definitely when you do this, the soft tissue scan is aligned with the denture scan. And now I'm scanning the opposing arch, and it becomes very easy. The patient bites over this, and technically I'm getting the proper jaw relationship from both sides, and it's done. Okay, so now I could get an impression for the tissues and a jaw relationship at the same exact single visit. And when we go to the software, we can do everything from there. This is actually for the planning, but we can do the same for the final restoration. When doing it for the final restoration, you might add another trick because you need to scan the scan bodies together with the soft tissue and the jaw relationship. So what we do is what we call the hybrid impression scan protocol. And with the hybrid impression scan protocol, what we get is like a plastic tray or an aluminum tray. And we take an impression the same way. We invert it into the positive model, and we put a piece of green stick compound on the top. In this patient, we were going to do like an all-on-4 in the lower arch, and we were going to extract those and make an immediate denture. So I just kept the anterior teeth here just to help me with the bite registration. Afterwards, I'm gonna clear them out. So the idea here is that you have to use your impression tray with the green stick to create the anterior stopper so that you can scan the patient. As you can see now, we have a bite for the patient. And then we take the tray out, we remove the green stick away, and we make holes in the tray, put it back inside the patient mouth, and we put the scan body and we scan them. So now we're using the tray for getting the shape of the fitting surface, for registering the jaw relationship, and to help recording the scan bodies together. And eventually it ends up with having a good soft tissue scan with the scan bodies together with a good jaw relationship in one step. And this is called the hybrid impression scan protocol. Okay, now I'm having an upper and lower edentulous patient. Probably I don't have good support. Can I use the green stick, the deprogrammer, directly over the soft tissue? You can, but really it's not very reliable because when the green stick becomes very big in size and not properly supported, it becomes mobile. So the relationship is not stable, and so your jaw relationship is not the best. Maybe you can use it for a tentative jaw relationship that you are going to correct later on, but really this is not the best way. It needs it requires a very professional prosthodontist and really very good control and cooperation from the patient. But still, it's a way. In this case, we are scanning the patient had the lower temporary and the upper is edentulous, and we want to construct the final restoration. So we just scan the patient and we create the deprogrammer over the soft tissue. We flatten the top, ask the patient to close, and we scan the patient. It's not the best thing to do, but probably can solve you give you like a tentative jaw relationship that might be corrected a little bit later on, as I'm going to show you. Okay, so now we have the first way, which is using the preoperative patient temporaries, or we can create a deprogrammer, an anterior deprogrammer to hold the vertical dimension using anything, the cap scan bodies, the regular scan bodies, the multi-units, and sometimes, which is less reliable, the soft tissue itself. But really, there is a very good way of doing it, which is using record blocks. I'm just telling you, if you have a problem, and you recorded the relation and it's not accurate, it's not a big fuss because you're going to do a try-in. So if you get the try-in from the lab, which is a fixed try-in, a PMMA try-in, and you start checking it. It's passive, but actually the jaw relation is not good. You don't have to do anything more. You just scan it. So in one of the cases when the bite was not very good, I just scanned the upper arch, and then I scanned the temporary. This is the temporary of the patient. And now I'm going to scan the bite from the right and left. And now you will see when we scan the bite, we have some spaces here, right here. So the occlusion is not perfect. And now I'm going to take this scan, send it back to the lab, and the lab can modify the original scans to the new bite. And this is what we call corrective scan for a proper centric occluding relation. So if your first scan with whatever technique you used before is not accurate, it's not a big deal. All what you need to do is that you scan the arches with the try-in, send them back to the lab, and he will correct the jaw relationship of the original scans, and he can do the restoration in a better way. And this is actually very easy and very reliable to do. The third way of recording the jaw relationship is to use record blocks. And really, this is, I believe, this is one of the most reliable ways, because this is the way we do dentures. Okay, but the problem is that it will need an extra visit, because you're going to scan the arches, and then you are going to design occlusion blocks. You're going to take in another visit the jaw relation record and scan it. We are used to do this with complete dentures. When we scan the tissues like this, I want to take a jaw relationship, I just take my scan, and on the software, we design occlusion blocks. You see, we design an occlusion block with a rim, which is a little bit short. We don't design it with long rims, because we're going to print this from resin and maybe add some wax later on. So I'm designing both occlusion blocks from the upper and lower arch, and we print them. The printed occlusion blocks are really a very good handy tool, because when you go back to the patient and you take the jaw relationship and probably demarcate the midline, the smiling lines, the canine line, and you take the bite, the jaw relationship, and you scan it, we can realign the original models to your jaw relationship. So it's a very nice way if you're doing denture and if you are doing implant restorations. But with implants, we have an extra advantage, because we are having implants in the arch. So the main problem with the occlusion record blocks in edentulous patients, that they are moving. So if they are moving during the jaw registration, the whole record is corrupted. They are not stable. So the best way to improve the accuracy of using your record blocks is to make what we call screw-retained occlusion blocks. When we design the occlusion blocks, we just make some holes opposite to maybe 2 or 3 of the implants in the arch. And before registering the jaw relationship, we are going to attach those using metal cylinders to the implant. So now the occlusion block is a screw-retained one. And we can take the bite conventionally, or maybe use something like a tracer. I'm going to show it to you in a minute now. So this is a 3D printed record block, and it has holes for what we call fixation to the implants. And what we need to do is that we get the upper occlusion block, put the cylinders, inject some core material or flowable composite, and cure it. And then we use like the wax or the bite registration material to adjust the vertical and the centric relationship. And then we scan the whole assembly, and the lab can adjust the original scans to the jaw relation record using this scan for the screw-retained occlusion blocks. Some people believe that biting on the anterior part or the lateral part is not the best way to make sure this is the centric, and this is why we had in the old days what we call tracers. Now we have the tracers are back again, because we have to design what this flat plane on the upper arch and this stylus with a screw in the lower arch that we can lower, get up and down to adjust the vertical dimension. And we can ask the patient to bite over this and maybe slide front and back, right and left, so that the point of the tip of the arrow, when the patient is moving front, it's making one straight arm, then right and left. So I mean, we are having like an arrow. The tip of the arrow is the centric position. So we ask the patient to move front, back, right, and left. And then at the tip of this arrow, we just make a small dimple, and the patient is biting over this. and we scan the bite from the right and the left. And this is called the tracers. We can do this. Those all are also screw retained occlusion blocks. We just fix the occlusion block here and the occlusion block here, and we just get this screw up and down till we reach the vertical dimension, and the patient is moving up on a record, up, front, back, right, and left on this median. And when we have the tip of the arm, we just put it here, a dimple, and the patient close over here, and we scan the bite right and left. So now the bite is more stable, the bite is more accurate, and you have a good jaw relationship. I'm going to show you a case that was extremely difficult to do to get the jaw relationship, to demonstrate the need for occlusion blocks in some cases. In this patient, he had like an infection, a fungal infection, that we removed the maxilla because we had a big fungal infection. And my colleague, Dr. Mustafa Taha, made those very nice quadzygomas and pterygoid implants for him. And he just sent me the patient after the surgery to make a bar and an obturator for him. So now I'm scanning the soft tissue first for this patient. I'm scanning the defect, margins, and the part of the soft palate. And definitely when I'm doing so, I just recorded the shape of the tissues. And then I'm going with the photogrammetry. I'm placing the photogrammetry scan bodies, because it's impossible in this case to use the conventional scan bodies. So photogrammetry here really is a saver. So I'm putting the photogrammetry here just to scan the location of the 6 implants, the multi-units over the 6 implants. And after registering the location of the photogrammetry scan bodies, for the guys who are not familiar with the photogrammetry, it's a different scanning technique. It's not regular optical scanning. It's a special scanner that has the potential to scan just the white dots over here and translate them to implant positions. And now we're doing something. We are just scanning part of the scan bodies and part of the soft tissue just to align them together. And eventually, when I finished, I'm now having a good scan for the case. And I go to the next step, which is identification of the implants. So I'm just changing the connection to the required implant connection. And I'm ready to work on the upper arch, but I'm missing a very important data, which is the jaw relationship. Here, there is nothing I can use to create a stopper. It's difficult to do this. So what we did now is that we scan the opposing arch. I'm scanning the opposing arch. It's a fully dentate arch. And eventually I'm having the upper arch and the lower arch, but I do not have a jaw relationship. And the homework here was to create an appliance for the jaw relation record. And this is what we did. On the lower arch, because we have teeth, we just created an occlusal splint for the lower. And for the upper arch, we're creating a verification jig for the passivity with a plate, a continuous plate like this. This plate is going to be the stable point where the tracer or the arrow of the tracer, the screw of the tracer will just hit. And now we have like 2 parts, an upper part, which is the passivity verification jig with a plate for the tracer. And we are having the lower part, which is actually an occlusal splint with a horizontal plate and an adjustable screw to adjust the vertical dimension. And what we need to do now is that we go to the patient mouth once more in another visit and place the upper part and the lower part, and we adjust the level of the screw until the patient bites at the proper vertical dimension we need, and we scan the bite from the right and we scan the bite from the left. So the use of record blocks is really important in the very complex case when you cannot guarantee a stable relationship with the deprogrammer jig. It requires more time and additional visit, but really in the very difficult cases, it's always a good way to go back and design occlusion blocks. You fix them over the implants and you adjust the bite and you take your recording. And eventually now we have the good jaw relationship. We design the bar and we design the denture, and this is how it looks. And this is how the obturator with the bar clips looks. So my take-home message today for everyone is that recording the centric occluding relation, the bite registration for all on X, have the same principles of doing a complete denture. We have to understand that I need to record the centric at the proper vertical dimension based on the facial measurements. The best way to do it if you have the patient template. This is the most reliable way. If not, you can do it in the same visit of the scan by creating an anterior deprogrammer by one of the different ways I showed you today. Maybe you can put on your imagination and maybe have a better way of doing it. It's just open to anyone to have a new idea of doing this. But the idea is just to stabilize the patient at the required vertical, at the correct centric, and do the scans from the right and the left. If you have a case which is problematic, you cannot stabilize and do the anterior deprogrammer, just go first to a scan. You get your scan first, and then you design record block. Better that you get your record block and attach them to metal cylinders to the implants so that they are stable, they are not moving, and then you take the jaw relationship and you scan it. Thank you very much for this. Those are my contacts if you want to contact me on Facebook, Instagram, and YouTube. And this is also our contact for our educational academy in Cairo. Feel free to contact us if you want to have like a comprehensive training on the prosthetics of full arches or any other topic. Just send us, scan the QR code, and contact the Cairo Implant Academy, and we'd love to have you in Egypt. Thank you very much for this, and I'm willing to receive your questions. Muhammad Bustani is asking, what material do we use for printed record blocks? You have two choices, actually three choices. The first choice is choose the tray material supplied by any manufacturer, or you can use the model material, just cure it properly, any model material. And of course, you can use the denture material, but it's a little bit expensive for this use. So probably I would use the tray materials. So now this is for the tray material, and then yes, Tom Hammert is asking for the STL for the screw retained. You can find it if you go to the Blender for Dental platform. It's a free file. You can download it. If you want to have it, I can send it directly to you, but just text me on the messenger. Just send me a text on the messenger. I can send you the STL file, but if you go to the site for Blender for Dental, it's a free file to install for the plate, the screw, and everything. Isra is asking about the segmented scan bodies. If you mean the scan body with the screw, I think this is supplied by a manufacturer. I might send you the article to read. This is not mine, but I've seen it in like a couple of companies. So I think it's prefabricated from some implant companies. Khalid Khurshid is asking how to design the 3D printed jaw tracers. I can send you guys the file, the file for the screw and the plate and at the top, and you can integrate it with the design. If you're using Exocad or Blender, I think you can add it very easily. Karim is asking, in edentulous patient with an unstable occlusion, mobile teeth, fracture restoration, is the yes, this is very good question, Karim. Karim is telling me if I'm having already teeth and the teeth are not good, they are mobile and the teeth are fractured, is the preoperative scan accurate? Definitely it's not accurate, Karim. When you have patient with teeth that are actually corrupting the jaw relationship, you cannot use this as the preoperative. Either you do what we call deprogramming, you just put a small deprogrammer like the one I show you, and you adjust this, you get the new centric relation, probably at a slightly higher vertical dimension, and then you need to record the radius using a face bow or a face scan, and then you can create the centric from this. Or you just pull them out and then you start scanning the jaw relationship with the final implants after you finish. But if the teeth, the existing teeth, are mobile and the centric is not good and it's not okay, don't use it as a preoperative record because it will corrupt everything. Orlando Alvarez is asking about the jaw tracking, the mobile jaw one. Really, Orlando, we're just working now with the MetiSmile from Shining and the jaw motion analyzer from Zebris. We are working on the workflow for edentulous patients. So probably maybe in few months when we have a next seminar, I will be showing you the workflow if you want to integrate a dynamic jaw relationship for a full arch cases using the MetiSmile. So just give me some time. We are working on this to get the best possible workflow for this. Okay, Karim is asking about the impression compound. The impression compound. He's asking if the impression compound would affect the stability of the teeth if the teeth are moderately compromised. This is the same question as before. The most important thing about using the anterior deprogrammers is that the foundation should be stable. If my foundation is movable, like the soft tissue, like a mobile tooth, the whole assembly will be moving. So the whole record is not accurate enough. So the most important thing about using anterior deprogrammers, whatever the type, is that the foundation should be a stable one. So if it's not stable, definitely the jaw relation record is not good. I'm just trying to cover the questions. Okay, Tom found it. Okay, so Amir. So now I think there are no more questions. I think I answered most of the questions. I would like to thank you all for your presence today. I hope the lecture was informative, and probably I finished the recording. It will be available on the platform. So thank you very much for today. Thank you.